I'm now going to hand over to our first speaker, Dr. Albert Power from Bristol.
Well, I hope everyone can see me. Hello. Thank you very much for the invitation to speak. This is something that I really enjoy. In fact, I usually end up learning more through the process. So I'll try and share my screen now and get cracking. And here we go. I'm hoping everyone can see this. I'll go right back to the beginning. And what I want to do is just run through the basics of polycystic kidney disease, what it is. I'll try and use understandable language. If I'm being too technical, can I ask you to sort of let me know, and I can try and explain some of the more technical terms. So, polycystic kidney disease, or PKD, is what's called a genetic condition. So this is the commonest genetic cause of chronic kidney disease or established kidney impairment. And it arises from the genes that we have inside all of our cells. Genes make us who we are. They comprise of lots and lots of information that's encoded in long pieces of string that are bundled up, as it were, into chromosomes that lurk inside our cells. And a gene is a single functional unit which is read and then makes things like proteins and the structures that make us who we are. Now, there are two forms of PKD that are described, and they are described based on the pattern of inheritance. And we're going to focus on ADPKD in this talk. So AD stands for Autosomal Dominant PKD. There is also autosomal recessive, and I'll go on just to briefly explain what that is, although I will leave the complex genetics to Richard. So that's one of the nice things about doing this talk, is that when it gets complicated, I can always leave it to another speaker. So autosomal recessive PKD is a condition that almost always manifests in children, young children. It's got quite a different pattern of kidney involvement, quite severe liver disease, and is out of the scope of this. For all those that don't know me, I'm an adult nephrologist, so I don't really see much ARPKD myself. It's mainly ADPKD. So autosomal dominant means that it is inherited through the chromosomes that we've got in our cells that are not the sex chromosomes, so not the X and Y chromosomes, but the others. And it's dominant because it is inherited through generations. You just need one copy of the gene to convey inheritance. And so there is typically a 50% chance of passing on that gene to the individuals in the next line of the family tree, and that they will, as a result, manifest that disease. So that's what autosomal dominant means. Now, the prevalence of ADPKD has been historically estimated at anywhere between 1 in 400 to 1 in 1,000 people. Some other series put it at 1 in 2,500, but it's nonetheless the commonest kidney disease that we encounter. And the way that it is inherited can affect its presentation. So some of you may know this, that there are two PKD genes that have been identified that cause polycystic kidney disease. Changes in PKD1 account for about 85% of the cases of PKD, changes in PKD2 accounting for 15%. And these sit on slightly different chromosomes. You don't need to focus on this, but just appreciate that PKD1 is the most common gene change that gives rise to the condition. And you may say, so what? Okay, you may say a doctor's just interested in the sciencey stuff, but what does that actually mean? Well, it's important to appreciate that PKD1 polycystic kidney disease, the symptoms of the condition tend to develop at an earlier age, and as a rule, it tends to progress faster than PKD2. So this is data from some time back showing quite a significant difference in the time of established kidney failure between the two groups. So people with PKD1 gene changes, dialysis start has been estimated at 54 years rather than 74 in PKD2, which tends to be a milder manifestation, as it were. Now, the other thing that we see is that the manifestation of the condition is not exactly the same, either within families or indeed as the family tree works down. So that the condition can sometimes be milder or more severe as you move down or across the family tree. And this is because of the genetics once more. The location of the gene change within the PKD1 or the PKD2 segment can alter the way that the condition is manifested. We know that the expression of these genes can vary from person to person, and there are sort of tagged on modifier genes that are inherited differently through the family tree, and these can affect the way that the gene is read and how intensively it's read, as it were. So how the condition appears in one person as opposed to another will be variable. Just trying to keep an eye on the chat as well as I go on, so apologies. Now, the kidneys, these are...
Can I just jump in? Can I just make sure that everybody can see the screen? And just to say that if the speaker's video is cutting across the screen, attendees, what you can do is you can drag that sort of speaker box sort of out of the way a little bit if it's, you know, if it's cutting across the information. Okay. And if you've got any questions, please feel free to put it into chat. Sorry, handing back.
No worries, no worries. Okay, with the kidneys, where are they? Well, they're sort of described as these little two bean-like things. So normally they're about, I don't know, roughly 10 centimeters in length. They kind of nestle at the back of the rib cage there, kind of in the area where you'd get some pain when you do some heavy lifting. So they kind of lurk back there. I can't actually show you on Zoom on myself, but if you sort of hold the back of the lower part of your chest near the back, that's where the kidneys would lurk. And these are two normal looking kidneys. I'll do a little rider. At one point in my talk, there's a little bit of a grisly picture of polycystic kidneys. There's only one of these, so anyone who doesn't like that, just look away. I won't linger too long. How do we find out if we've got one or two kidneys? I see that in the chat. Well, you don't get any symptoms, actually, so it's very difficult to know whether we've got one or two kidneys when we're born. We don't get scanned at birth routinely unless there is clinical concern. And so usually people would typically find out they've got one kidney when they have scans performed for other reasons. So for example, I don't know, gallbladder pain, and someone gets a scan to look for gallstones, they will tend to image the whole abdomen. Ooh, PKD type, okay. So that is based on genetics. So it's a genetic test that you do to see whether you've got the PKD1 or PKD2 gene mutation. So I'll go back to the kidneys. All right, a brief whistle-stop tour. So this is what a kidney looks like if you just take it and slice it down the middle. So it's got a sort of a functional rind out here. Ooh, it's moving on. A functional rind out here called the cortex, and then you've got this inner bit here called the medulla. And the urine is made in these millions of these little individual units called nephrons that we've got that do all the filtering and the post-processing. And urine is made, and then it all pools here in the renal pelvis and then comes out down here through the ureter into our bladders, and we wee it all out. So if we look at these functional units, we've got the filtery bit here, which is called the glomerulus. So some of you may, for example, be checking blood tests and looking at GFR, or glomerular filtration rate. The estimate of that is derived from your blood tests. Well, that's all happening here in the glomerulus. So the blood gets filtered here, and then fluid that is filtered out wiggles its way all through here into the tubules. You get concentration of the urine. So in other words, if we didn't have any urinary concentration going on, we'd pee out all the fluid that we'd filtered, and we'd gradually dehydrate and become something like a Ryvita very quickly. So it's a very good system to have, urinary concentration. And then as urine flows through here, you get regulation of blood salts and excretion of other toxins that then come out in our urine. And the reason I show this is just to try and highlight where the tubules really are, because that's where the business occurs with PKD. So moving on here, you've got a tubule, okay? And you've got all these tubular cells that make it up. And if we look at each of these separately, you'll see that they've got little frond-like extensions on the inner surface. So urine would flow that way, and you've got these things called cilia that protrude into the center, into the center of the lumen. And it is these and the impact of polycystin 1 and polycystin 2, these are the encoded proteins that were sitting on the cilia that were felt to mediate some of the early changes of PKD. I'm not going to do a long description about the cilia. Again, I will defer to some of the speakers who will come later on to talk about cilia and PKD research. But just to highlight, this is the area where those proteins sit that are encoded by the PKD genes. And you may say, well, all right, that's all very good. And here's another complicated picture, Bert. Very nice. I'm sure you understand it. And I'm not showing this for detail, other than to try and highlight a couple of little bits other than polycystin. And just to say, when I see Graham's appeared there. Hello, Graham. Talking about tolvaptan. And its effect on the vasopressin receptor, you'll see that it lurks down here and is involved in some of the cell changes that occur within these tubular cells that lead to cyst growth. So that was the reason of just bringing up this slide, just to introduce what's going on here. So on the Q&A, sorry, I'm just sort of going in on this. There's a question about genetics, which I might defer later on to Richard. What I'm showing here in answer to the second question is this is the tubule. These are the distal tubular cells that I'm demonstrating here. So it's not the whole length of the nephron. Typically, the cysts develop as little outpouchings here, tiny little cysts along the length of the renal tubule. They probably affect about 1% of the total number of tubules. And eventually the cyst gets bigger and then detaches to form multiple little cysts and larger cysts that you can see here in 2 polycystic kidneys that were removed. So you can see that the cysts would get larger and larger. You've got a little bit of a compression and scarring of adjacent kidney tissue. And as a result, kidney function can decline over time. Now, what I've discussed so far is looking at microscopic changes. Okay, and microscopic changes we wouldn't be expecting to see or appreciate that they're there at a very early stage. So how do people get diagnosed with ADPKD? Well, there are some people who've got a clear family history of the condition. And so therefore, sometimes they're diagnosed with PKD following routine screening with ultrasound, for example, where there is a clear family history of the condition. Some people get diagnosed with PKD, for example, when they get a kidney scan as part of workup for the diagnosis of new onset high blood pressure, hypertension, most typically in people who are younger. In other words, in age groups where you wouldn't classically expect hypertension to develop. They go on and see the GP might order a scan and some blood tests, and multiple cysts are delineated on the scan. And it might indeed be an incidental finding. So ultrasound during pregnancy, scanning as a result of having had a blow, very painful, persistent blow to the back, or people who develop frank blood in the urine or are prone to recurrent urine infections. So those often trigger a scan of the kidneys, and then the report comes back and is indicative of a diagnosis of PKD. But not everyone will have a family history of PKD. When you do a scan, this is typically what you see. So ultrasound scanning works by looking at shadows. And this is an ultrasound scan of a kidney filled with lots and lots of these, oops, let me go back again, apologies, lots and lots of these fluid-filled cysts that you can see here, taking up a significant proportion of the kidney matter. So it's important to understand whether there's a family history, because clearly in an individual who's not been diagnosed yet but comes from a family with a clear family history of PKD, it is quite likely that if there are multiple cysts in the kidneys, that they too have PKD. As I said earlier, in a proportion of people, estimated at 25%. There's been other data showing about 15% of people who have got ADPKD. There is no clear family history, and that usually arises when they develop new gene changes that weren't there before, but these gene changes affect the PKD genes and result in multiple kidney cysts. So certainly in my practice, yes, indeed, there's a number of people who come from families where PKD is prevalent, but there is a not insubstantial number of my patients in whom there is no clear family history of the condition. It's important to see, to look at the kidney cysts, look at how many there are, and I'll come to that briefly, and particularly where they sit in the kidneys. And age is important. As we all get older, as it were, we are allowed slightly more cysts in the kidneys as being normal. And the younger we are, we shouldn't really be seeing multiple cysts in the kidneys. And appreciating that has, oops, I'll go back there, has led to the use of imaging to be a sort of diagnostic route to figure out whether people Sorry, I'm looking at the Q&A, so I've got slightly distracted. Yes, so imaging has been used as a form of diagnosis. So ultrasound has been the conventional route. CT, MRI can also be used. These two here give you a much better degree of detail. So you tend to see the smaller cysts. Ultrasound scan will typically pick up cysts about 1 centimeter in size. CT and MRI picks them up a couple of millimeters in size, etc. So you typically are allowed more cysts in MRI before you make the diagnosis. A number of questions. I'll just address these now before moving on, because there are some questions about cysts. There is a question about genetics and at what stage would you screen a newborn, and inheritance questions. What I might do, if that's all right, is again ask Richard to touch on those because that would be helpful. Does the number and size of cysts correlate directly with kidney function? Well, the amount of kidney enlargement as a result of cysts does correlate with kidney function. So as the cysts become more numerous and larger, and their compressive effect on normal kidney tissue increases, then yes, you do see a reduction in kidney function over time. And Graham may indeed touch on the use of total kidney volume as an indicator of PKD and kidney disease progression and how it impacts on decisions about tolvaptan therapy. Can you have different stages of PKD in each kidney? Well, the number of cysts that you get in each kidney can certainly vary, although usually by the time people develop established disease, it's difficult to say how much the difference is between right and left. There are numerous cysts in all kidneys, but yes, you can have asymmetric involvement of right versus left kidney. We do sometimes see this in people, that one kidney is significantly larger than the other. Another question about MRI scanning to determine how large the kidneys are. This is the gold standard pretty much in terms of trying to determine total kidney volume. Some places where their scanning departments are particularly evolved and skilled in scanning kidneys for size will be able to do that in an effective and reproducible way in a single patient, and then you can judge how the kidneys are getting larger. But if you want to do a proper volume measurement and track change over time, use of MRI is the best way to do it. It's obviously time consuming as MRI scans take a lot longer than CTs, which take a lot longer than ultrasounds. Screening for ADPKD. I put this first line in here. This is a little controversial and I'm not sure I particularly believe it anymore, but the traditional line was that screening for ADPKD was not recommended in those under 18 years old. That's probably a little paternalistic now as we come to appreciate the condition and particularly how it affects children. One needs to be aware that when one screens for a condition and diagnoses a disease state, that is going to have an impact, isn't it? And we feel that as adults, and it'll be felt so much more so potentially in children. So what impact will the diagnosis have on psychological well-being? What impact will the diagnosis have on life choices, let alone insurance? But part of this recommendation was a concern that if you used, for example, ultrasound to screen for multiple kidney cysts in children, you might miss true PKD because they haven't developed to a size at which ultrasound will pick them up. And so you've got to let time elapse. And the recommendation was that you did ultrasound scanning when actually it was able to deliver some discrimination in terms of whether that person had evidence suggestive of PKD or not at all. And you will see here some consensus ultrasound criteria on how many cysts you have before the imaging, the ultrasound imaging, which is what I'm showing you here, is indicative of PKD. And the first thing you will notice is that the criteria vary on whether this is scanning someone whom we know has a family history of PKD, and here it mentions of PKD1 heritage, or scanning people in whom the family history and the genetics is not known. So in the under 40s, the presence of 3 or more cysts, be they occurring on one kidney or between left and right kidneys, in someone in whom the genetics is not known, is highly suggestive of ADPKD. And the number of cysts in those from a PKD1 heritage, that criterion is slightly lower when that is known. In people over the age of 40, again, you will see this effect that I said about the number of cysts that you are, inverted commas, allowed to have. That increases as you get older. But if you've got, let's say, 3 or more cysts present on the right and on the left, actually, and you are 50, this is highly suggestive of ADPKD. Just going to have a quick look here at the Q&A and the chat to make sure that I'm not missing anything. There's a question here. Again, a lot of genetics, and this is always the hot topic, really, particularly as we move to a more gene-based approach to medicine. Do you know what causes gene changes when there is no family history? I might leave that to Richard again. In a lot of cases, we don't know why the gene changes occur. The risk of gene changes occurring of course, increases with every time our cells replicate, and we have to sort of copy out longhand, as it were, all our genetic information. And then there is a comment about someone whose child was diagnosed with PKD on antenatal scanning when 3 cysts were diagnosed at that very early age in the infant that was not yet born. So yes, unusual, but it can be detected on antenatal scanning, as you say, on a 20-week scan. So I'm going to move on now, and I'm hoping between Jane and Tess, you're keeping an eye on the time, so you can wrap me on the knuckles if I need to speed up. So what does ADPKD do? And I put there in a box kidney complications, and you might say, gee, I think we figured that out. But what are the kidney complications? Well, with cyst enlargement and issues that may arise, and I'll explain these, affecting kidneys, issues like infection. For example, one can see a worsening of kidney function over time. So the development of more established forms of CKD, which can progress on to end-stage renal disease. The kidney's ability to concentrate urine, remember I was talking about Ryvitas and stuff in an early slide, So the ability of the kidneys in polycystic kidney disease to concentrate urine and reclaim all that filtered fluid is not quite as good. And some people find this quite troubling in that they tend to pee lots and as a result be really quite thirsty. And I've not even mentioned the tolvaptan word here. Not everyone, but a certain proportion of patients do experience that as a real issue. Infections, so not just urinary tract infections, but there's really painful cyst infections that can give fevers, quite severe pain, and sometimes lead to hospitalization. This can be a real problem for some people with PKD. And cyst hemorrhage. This can be extremely painful. Sometimes you don't necessarily need to see blood also coming out in the urine, although that can happen if the cyst ruptures and then communicates in with that sort of drainage system. So if you remember, I showed you the renal pelvis extending out to the ureter. So you can sometimes have visible bleeding or visible hematuria, as the doctors tend to call it, which can happen spontaneously. And there is a higher than average predilection to kidney stones in PKD. And this, of course, will be compounded by dehydration, particularly if you don't keep up with the fluid intake. And pain. Pain is difficult to manage in some cases. It doesn't always seem to link to the size of the kidney cyst. It will affect people variably and sometimes is the dominant symptom, even without a significant amount of kidney dysfunction. Difficult to treat. Often it necessitates repeated visits to the A&E. Nephrologists tearing their hair out, patients tearing their hair out, trying to find a solution. Sometimes identifying a culprit cyst and draining it can help. It can be temporary. Sometimes deroofing the culprit cyst surgically and just leaving it open so it doesn't close up again and fill up with fluid can be helpful. And there's a little bit of data to suggest that tolvaptan may help with pain. So that for me is always the big bugbear and leaves me feeling helpless, let alone the person I've got in front of me.
Albert, can I just jump in here and ask you to explain a little bit about deroofing? Okay,
so yeah, a cyst is a sort of closed structure like so. I'm hoping you can see me on the video. So, you know, if you drain it, it'll shrink down, but then fluid will reaccumulate in the middle and it will re-expand. One way of trying to prevent that and try and offer a definitive solution to that is just to open up the top. In other words, take the roof off and stitch the top bits to the side so it just remains open. So it doesn't close back up again and fill up with fluid and recur. There was a question here about rapid decline in kidney function, quoting an EGFR change, for example, from 70 to 55 in a matter of months. EGFR is a tricky little thing because it is the result of a mathematical equation that takes into account age, gender, there is an ethnicity correction factor, and then actually the raw level of creatinine. And as an estimating equation, it's got a degree of inaccuracy associated with all the values it spits out because it's just an estimate. And this splay in accuracy becomes wider and wider and wider as the creatinine becomes more and more normal. So it's not uncommon to see a creatinine change, let's say from 50 to 58. On the blood tests, leading to a much wider change in the calculated EGFR. And you could easily go from a creatinine of 50 to 58, let's say, if you're a little bit dehydrated from one day to the other. You've got some lab analyzer error, even before we throw in something like, I don't know, trimethoprim to treat a urinary infection. So EGFR can shift around quite sharply. and then you're therefore going to be prone to seeing more dramatic changes within that zone of 70 to 55 that may reflect true loss of kidney function or an exaggerated representation of mild creatinine fluctuation. So I would normally be repeating that and actually tracking the creatinine myself rather than eGFR. If a cyst is suspected to have ruptured, how long would you expect to see microscopic blood in the urine, was the question. In other words, I presume this is a question about having non-visible hematuria. Oh, crikey, some people with PKD can have microscopic hematuria ongoing. It's always important to make sure that it's coming from the kidneys and not from lower down. If it was directly related to a bleed, I would expect it to be present for a couple of weeks before settling. I'm going to move on now. There's loads of questions, but I've got to move on, and I'll try and answer some of the others as I go on if I've got time. Other problems, and this might answer one of the questions. So hypertension. It's recognized that even in kids with PKD, probably around about 20 to 40% of them will have hypertension. And we're not that fantastic at diagnosing it in children. We tend to think of hypertension as an adulty thing. In adults with PKD, the prevalence, so the amount of people who would have high blood pressure, would vary anywhere between kind of 50 to 70% of people with PKD. And this tends to be present in that proportion even before there is clear evidence of kidney function decline. So managing hypertension is a key part of medical treatment for people with PKD. Stroke risk. This is an issue of great concern. I do note it sort of ranked amongst the top 5 issues and areas of interest for research when internationally researchers reached out to people with PKD. So risk of stroke, and particularly this is subarachnoid hemorrhage. So it's a type of a bleed stroke, not a sort of stroke caused by a clot. We appreciate that there is a higher risk of subarachnoid hemorrhage in people with PKD who have a strong family history of subarachnoid hemorrhage. And in those cases, screening of brain arteries is recommended. The effect of organ enlargement, kidneys getting larger, making it difficult to move, in some cases actually breathe if there is a lot of pressure on the diaphragm, and particularly if there is a lot of liver involvement. This can make life difficult. Significant liver involvement in PKD can also cause problems with eating, so early satiety, not being able to eat large meals, having to eat little and often, and can sometimes, in extreme cases, cause problems with nutrition. So this is not an insignificant issue, and it does impact sometimes on surgical access for transplantation. And I'll leave Sam to talk about that in his talk. Polycystic kidney disease is associated with a higher risk of developing hernias, as well as little outpouchings of the lower part of the bowel, or diverticulae, which can sometimes become inflamed and give rise to diverticulitis. I mentioned liver involvement. Liver failure as a result of PKD is actually really rare. So when I mention liver involvement, it's the impact really of cyst growth within the liver, the space problems that it causes, the risk of some of these cysts becoming infected being the dominant issues. So coming towards the end now, so what does one do? What does one do? I can remember days when it was pretty much an, oh, well, can't do very much here. It's a genetic condition, and there you go. We just sit tight and see you once a year. The advent of tolvaptan has shifted that paradigm quite significantly, and there is a fair amount of research ongoing to see whether there are other therapeutic agents that may help. But I'm not going to step into the research realm in this talk. Blood pressure, blood pressure, blood pressure. You'll probably hear kidney doctors going on ad nauseam about blood pressure control. It's absolutely vital. It's one of the single pillars of achieving kidney function stabilization in pretty much all forms of kidney disease. As a simple rule of thumb, 130/80 millimeters of mercury would be the target for most forms of kidney disease. In PKD, there is some evidence to suggest that actually slightly lower blood pressure targets yield even better protective results. So I tend to go for blood pressures typically lower than 120/75 millimeters ideally, and with preferential use of either medicines ending in pril or sartan. So these are medicines called ACE inhibitors or angiotensin receptor blockers. Choose one or the other to go for. I'm not aware of any evidence showing that one is better than the other, but they are useful. Were designed as blood pressure lowering agents, but they also have an add-on effect at limiting some of the kidney scarring pathways. And so from this point, actually deliver a double whammy of benefit. So blood pressure control, really, really important. Tied to this is control of dietary sodium. So you'll probably have heard from other sources about salt and its impact on blood pressure. So, I don't know why it's doing this. So make sure that you are adhering to either a no or a low salt diet, if at all possible, to try and help with blood pressure control. Other advice really stems around dietary fat, control of lipids, and an understanding that where renal impairment occurs, there are greater rates of cardiovascular disease, so heart problems, strokes, problems with the arteries to the legs. And if cholesterol is high in those cases, then there is typically a role for cholesterol tablets like statins, although there is as yet that I'm aware of no clear data showing that statins directly affect cyst growth and thus reduce the progression of PKD. Fluid. Drink lots and lots and lots and lots. This is quite difficult, and I haven't even said the tolvaptan word below. So there is some theoretical evidence that actually maintaining a high fluid intake may indeed reduce the amount of vasopressin that we all produce. I mean, it should do, because as we reduce the amount of vasopressin we produce, we pee more. Alcohol has the same impact. And so therefore, if you remain well hydrated with a high fluid intake of more than 3 liters a day, I'd probably suggest naturally you'll be pushing vasopressin levels down, and that is potentially going to have a beneficial effect on cyst growth. The other good thing about a high fluid intake, it means you pass lots of dilute urine, which reduces your risk of developing stones and getting ascending urine infections. So there is a fair amount of good advice there about maintaining a high fluid intake. I also tend to tell people don't just drink loads and loads and loads of water, mix it up so that the blood salts don't become too dilute if one's guzzling 7 liters of pure water a day. And tolvaptan I will leave to the end. So I've come to the end. I might just see whether I can answer some of the other things on Q&A, if that's all right.
Just jumping in, Albert, we've just a bit quick time check. We've a few more minutes before we move on to
Sure.
our next speaker.
Okay. So very quickly, immunosuppressants destroying kidney function in the setting of a liver transplant. Yeah, that's tricky. So it probably, the questions about tacrolimus and what impact that has on kidney function. We know that sustained, in other words, many years worth of exposure to particularly high levels of tacrolimus can cause progressive kidney scarring and loss of kidney function over time. Transplant centers are usually aware of that and would adjust the tacrolimus dose to the minimum necessary to preserve organ function. So I would expect the liver unit to take those necessary steps. And sometimes there is a change of immunosuppression away from tacrolimus to other things like mycophenolate or azathioprine that don't have an impact on kidney function. What do I mean about mixing it up with fluid intake? Water. Well, I tend to say water, squash, kidney function allowing, as long as it doesn't put potassium up, fruit juices, just something that doesn't lead to pure water dilution of the blood and a drop in the blood serum sodium. So, 8 liters of pure fluid a day, particularly if you're not peeing that well, can lead to dilution. Alcohol and kidney function, no direct data to suggest that alcohol is harmful to kidneys. Of course, the problem with alcohol, particularly lots of it, is, as I said, that you tend to become dehydrated because you pee lots and lots, and that probably isn't so good for kidneys. So I'll stop there, Jane, if that's all right.
I was just going to ask you, I've just, there's an interesting one about salt intake. I mean, it comes up a lot, this. I wondered if you could quickly answer that one.
Having said no salt, it's pretty difficult to do no salt. Probably somewhere about 1 to 1.5 grams a day of salt might be reasonable. Salt sneaks in to our diet, and it's snuck in particularly on prepared foods and where we're not expecting to see it. So although we might be careful about not putting salt in our cooking, actually the stuff we buy and we get, particularly from supermarkets, has likely got a lot of added salt in it. So controlling that would be sufficient to help manage blood pressure. It's not going to be the only mechanism.
Thank you. Okay, so I think we've come to the end of that session now. Thank you so much, Dr. Power. Hopefully that has given you